Cirrhosis develops progressively as a result of damage to the liver, which can be due to a number of causes, usually over a number of years. The normal smooth liver structure becomes distorted, with nodules surrounded by fibrosis. This affects the liver's synthetic, metabolic, and excretory actions. Classification. Cirrhosis can be described as compensated, when the liver can still function effectively and there are no or few noticeable clinical symptoms. Decompensated, when the liver is damaged to the point that it cannot function adequately in overt clinical complications, such as jaundice, ascites, variceal hemorrhage, and hepatic encephalopathy. Events causing decompensation include infection, portal vein thrombosis, and surgery. The Child-Pugh, also known as the Child-Pugh-Turcotte classification system, is a widely used and validated way to estimate prognosis in those with cirrhosis. A score of 5 to 6 is classed as life expectancy 15 to 20 years. A score of 7 to 9 is class B, life expectancy 4 to 14 years. A score of 10 to 15 is class C, life expectancy 1 to 3 years. This aligns with a perioperative mortality for abdominal surgery of 10%, 30%, and 80% respectively. Causes and risk factors. Recognizing risk factors early and managing them effectively may help prevent the development of cirrhosis or slow its progression. However, not everyone with risk factors will develop cirrhosis. The most common risk factors for cirrhosis in the UK and Europe include alcohol misuse, hepatitis B and C infection, obesity, body mass index of 30 or more, or type 2 diabetes. People in these groups are at risk of cirrhosis if they have non-alcoholic fatty liver disease, NAFLD. If NAFLD is not present, they are not at immediate risk of cirrhosis from obesity or type 2 diabetes alone. Non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, up to 10% of patients with NASH can develop cirrhosis. Less common causes of cirrhosis include autoimmune liver disease, for example, autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, genetic conditions, for example, hemochromatosis Wilson's disease, alpha-1 antitrypsin deficiency, cystic fibrosis, glycogen storage diseases. Medication use, usually over a long period of time, for example, methotrexate, amiodarone, and isoniazid. Budd-Chiari syndrome or veno-occlusive disease, sarcoidosis and glycogen storage disease, infections including congenital and tertiary syphilis and schistosomiasis. Complications. Around 80 to 90% of the liver parenchyma needs to be destroyed before there are clinical signs of liver failure. Hence, many are unaware of their cirrhosis, which may be discovered coincidentally. However, there is often a poor correlation between the histological findings and the clinical picture. Portal hypertension, a pathologic increase in portal venous pressure, is one of the earliest sequelae of cirrhosis, and many complications of cirrhosis arise as a result of this rather than hepatocyte failure. The fibrosis causes distortion of the hepatic vasculature and can lead to an increased intrahepatic resistance and portal hypertension. The major complications of cirrhosis are ascites is fluid accumulation in the peritoneal cavity as a result of splanchnic vasodilation and sodium and water retention. It causes abdominal swelling, bloating, and pain, and is the most common complication of cirrhosis, often necessitating hospital admission. Hepatic hydrothorax occurs in around 1 in 20 people with cirrhosis and ascites. This is a large ascites and usually on the right side, resulting from fluid passing through a defect in the diaphragm into the pleural space. People with cirrhosis and ascites are at high risk of further complications such as spontaneous bacterial peritonitis, hyponatremia, and hepatorenal syndrome. Hepatic encephalopathy. Hepatic encephalopathy is a dysfunction of the brain as a result of liver insufficiency and/or portosystemic shunting and is related to the effect of nitrogenous waste products such as ammonia and glutamine on the brain. It is a frequent and debilitating complication of cirrhosis, affecting quality of life and increasing the person's risk of accident. It presents with a variety of symptoms, including cognitive and behavioral changes, for example, irritability, disinhibition, disorientation, personality changes, sleep disturbance, motor problems, and altered level of consciousness. Symptoms vary in severity, with mild hepatic encephalopathy, only detectable using psychometric or neurophysiological testing, in severe cases experiencing acute confusion, agitation, and coma. Hepatic encephalopathy affects around half of people with cirrhosis sometime after diagnosis, 5-25% within 5 years, and around 1 in 5 people with cirrhosis each year, and is more common in people with other evidence of decompensated liver. It is usually associated with a predisposing event, for example, constipation, dehydration, infection, gastrointestinal bleeding, or drugs, for example, opiates, benzodiazepines, diuretics. Hemorrhage from esophageal varices. The increase in portal pressure causes varices as a result of dilation of veins in the esophagus and stomach. Rupture of varices and associated bleeding, which can present as hematemesis or melena, has a high mortality rate. Risk factors for rupture include size of varices, severity of liver disease, sepsis, and hepatocellular carcinoma. Gastroesophageal varices occur in around half of people with cirrhosis, but this is dependent on the clinical stage. Fewer people with compensated cirrhosis have varices 30 to 40%, compared with decompensated cirrhosis, up to 85%. Young people and adults with cirrhosis and upper gastrointestinal bleeding should be given prophylactic intravenous antibiotics at presentation. Offer endoscopic variceal band ligation for the primary prevention of bleeding for people with cirrhosis who have medium to large esophageal varices. Transjugular intrahepatic portosystemic shunts are indicated for people at high risk of failing with standard therapy. Infection people with cirrhosis are at increased risk of bacterial infection and sepsis because of immune dysfunction resulting from cirrhosis. The most commonly occurring infections in this group are spontaneous bacterial peritonitis, when the body's natural bacteria cause infection of acidic fluid, urinary tract infection, pneumonia, cellulitis, and bacteremia. SBP caused by the spread of bacteria across the gut wall and/or hematogenous bacterial spread. Escherichia coli is among the most common organisms implicated. This may be prevented by adequately treating ascites and treating those with high neutrophil counts in their acidic fluid, greater than 150 neutrophil, with empirical intravenous antibiotics, and albumin patients who survive an episode of spontaneous bacterial peritonitis should receive long-term prophylaxis with oral antibiotics such as norfloxacin, ciprofloxacin, cotrimoxazole, or trimethoprim. Bacterial infections have a significant role in progression of liver failure, development of complications, and mortality in people with cirrhosis. The body's response to infection increases the risk of serious complications such as shock and renal failure because of the hemodynamic dysfunction that is already present in cirrhosis. Risk factors for infection in people with cirrhosis include reduced liver function, low protein ascites, and variceal bleeding. Around a third of bacterial infections are acquired in the community, and the incidence of resistant bacteria has increased in recent years. Anemia, thrombocytopenia, and coagulopathy. Anemia may result from folate deficiency, hemolysis, or hypersplenism. Thrombocytopenia is usually secondary to hypersplenism and decreased levels of thrombopoietin. Coagulopathy results from decreased hepatic production of coagulation factors. If present, cholestasis causes decreased vitamin K absorption, leading to reduced hepatic production of factors 2, 7, 9, and 10. Patients with cirrhosis also may develop fibrinolysis and disseminated intravascular coagulation. Hepatocellular carcinoma. 80% of hepatocellular carcinoma is caused by hepatitis B and C infective causes of cirrhosis, and 10 to 20% of cases are caused by alcoholic cirrhosis. Patients with cirrhosis should be screened for hepatocellular carcinoma. The American Association for the Study of Liver Diseases and the European Association for the Study of the Liver guidelines recommend at least one screening per year for hepatocellular carcinoma in patients with cirrhosis, using imaging with ultrasonography, triphasic CT, or gadolinium-enhanced MRI. Screening using serum alpha-fetoprotein is no longer recommended because of its poor sensitivity and specificity. Other complications include hepatorenal syndrome, results from changes to the circulation due to the effects of cirrhosis, plus sodium and water retention and renal vasoconstriction. The resulting decrease in renal blood flow leads to a reduced glomerular filtration rate and hepatorenal syndrome. Portal hypertensive gastropathy, portal vein thrombosis. Cardiovascular complications, including circulatory changes such as decreased blood pressure and cirrhotic cardiomyopathy. Prognosis. Once cirrhosis has occurred, it is usually considered as irreversible. In patients with the three most common causes of liver disease, hepatitis C, and alcoholic liver disease, 10 to 20% will progress to cirrhosis within 10 to 20 years. People with cirrhosis are generally well and have no clinical symptoms or signs for a period of time, which varies depending on the person affected but may be a number of years. Eventually, complications such as jaundice, ascites, variceal hemorrhage, or hepatic encephalopathy arise due to portal hypertension and/or hepatocellular failure. This marks the transition from compensated to decompensated cirrhosis. The prognosis of cirrhosis is influenced by a number of factors, including underlying cause. Successful treatment of the cause may prevent additional liver injury. For example, antiviral treatment for hepatitis C. Lifestyle changes. Obesity and alcohol use have prognostic relevance in people with cirrhosis, regardless of the underlying cause. Development of complications. Median survival in the compensated stage is more than 12 years. In the decompensated stage, it is around 2 years. Suspect cirrhosis. In high-risk groups, especially if there are non-specific symptoms such as malaise, fatigue, anorexia, nausea, weight loss, muscle wasting, or abdominal pain. If examination identifies palpable left lobe of the liver, hepatomegaly, splenomegaly, the presence of stigmata of chronic liver disease, spider nevi, palmar erythema, white nails, muscle wasting, features of severe liver impairment and signs of decompensated liver disease, such as jaundice, examine the sclera under natural light. Abnormal bruising, peripheral edema, ascites, sepsis, variceal bleeding. Encephalopathy. A sign of this is asterixis. Sudden involuntary flexion extension movements of the wrist and metacarpophalangeal joints when the arms are extended, the wrists dorsiflexed, and the eyes closed for at least 30 seconds. If a person is known to have chronic liver disease and has a low platelet count, elevated aspartate aminotransferase, alanine transaminase ratio, high bilirubin, low albumin, or increased prothrombin time or international normalized ratio. Note that liver function tests may be normal in cirrhosis, so the whole clinical picture should be taken into account. In a person not known to have liver disease, consider chronic liver disease as a possibility and investigate if there are persistently abnormal liver blood tests. Cutaneous features of cirrhosis include jaundice, scratch marks secondary to pruritus, spider angiomatanivi, mainly found on the trunk and face, skin telangiectasias, called paper money skin, palmar erythema, bruising, petechiae or purpura, hair loss, white nails, horizontal white bands or proximal white nail plate, sign of hypoalbuminemia, finger clubbing, Dupuytren's contracture. Other signs include hepatomegaly and a nodular liver, edema, gynecomastia, and male hair loss pattern. Hypogonadism, testicular atrophy, amenorrhea, due to the direct toxic effect of alcohol in alcoholic cirrhosis or iron in hemochromatosa. Kayser-Fleischer ring, a brown-green ring of copper deposit around the cornea, pathognomonic for Wilson's disease. Signs of portal hypertension include ascites, can be detected clinically when greater than 1.5 liters of fluid is present. Caput medusae, veins seen radiating from the umbilicus. Enlarged spleen, signs of hepatic encephalopathy, asterixis. Flapping tremor, suggests hepatic encephalopathy. To detect asterixis, take the patient's hand and gently hyperextend the wrist and joints of the hand, pushing gently on the tips of the forefinger. Hold that position for several seconds, and you will feel a slow clonic flexion relaxation movement against your hand if asterixis is present. Diagnosing cirrhosis. Blood tests. LFTs should include aspartate transaminase, alanine transaminase, ALT, alkaline phosphatase, ALP, bilirubin, gamma-glutamyltransferase, gamma-GT, AST and ALT are raised due to hepatocyte damage. Gamma-GT is high in active alcoholics. Albumin. There is hypoalbuminemia in advanced cirrhosis. FBC. Occult bleeding may produce anemia. Hypersplenism may cause thrombocytopenia. Macrocytosis can suggest alcohol abuse. Renal function tests and electrolytes. Hyponatremia may be present due to increased activity at antidiuretic hormone. Poor renal function may represent hepatorenal syndrome. Red cell folate. Alcohol abuse is often associated with a diet inadequate in folate. Coagulation screen. Abnormalities of coagulation are a sensitive test of liver function. Prothrombin time is reduced in advanced cirrhosis. Ferritin. Low ferritin may indicate iron deficiency from diet or blood loss. Ferritin is raised in hemochromatosis. Viral antibody screen. To look for evidence of hepatitis B or C infection. Fasting glucose, insulin, triglycerides, and uric acid levels. These should be measured if NASH is suspected. Autoantibody screen. Anti-mitochondrial antibodies are a very strong indicator of primary biliary cirrhosis. Alpha-1 antitrypsin level. To assess for alpha-1 antitrypsin deficiency. Ceruloplasmin and urinary copper. To look for Wilson's disease. Imaging ultrasound scan of liver and possibly CT or MRI scan. Their main use is to detect complications of cirrhosis, such as splenomegaly, ascites, or hepatocellular carcinoma. This may show an elevated diaphragm and even pleural effusion due to the passage of acidic fluid across the diaphragm. Offer transient elastography, if available, to diagnose cirrhosis for people with hepatitis C virus infection, men who drink over 50 units of alcohol per week, and women who drink over 35 units of alcohol per week and have done so for several months. People diagnosed with alcohol-related liver disease. If transient elastography or expertise and training in the interpretation of transient elastography results is not available in primary care, or for people in whom transient elastography is not suitable, refer to a hepatologist or gastroenterologist for further assessment for the presence of cirrhosis. For people with NAFLD and advanced liver fibrosis, as diagnosed by a score of 10.51 or above using the Enhanced Liver Fibrosis ELF test, if available. Offer either transient elastography or acoustic radiation force impulse imaging to diagnose cirrhosis. For people who are obese, BMI of 30 or higher, or who have type 2 diabetes, do not offer tests to diagnose cirrhosis unless they have NAFLD and advanced liver fibrosis, as diagnosed by a score of 10.51 or above using the ELF test. For people with other liver disorders, for example, primary biliary cholangitis, primary sclerosing cholangitis, hemochromatosis, Wilson's disease, in whom cirrhosis is suspected, seek advice from the person's specialist or refer to a hepatologist or gastroenterologist regarding assessment for cirrhosis. Retesting if cirrhosis is not diagnosed on initial testing. Offer retesting for cirrhosis every 2 years for people diagnosed with alcohol-related liver disease, people with hepatitis C virus infection who have not shown a sustained virological response to antiviral therapy, people with NAFLD and advanced liver fibrosis. Referral. For all people diagnosed with cirrhosis and transient elastography, refer to a specialist in hepatology. Following referral and specialist assessment, it may be considered appropriate for a person to be managed in primary care or using a shared care model. For people who develop decompensated liver disease, refer immediately to a hepatologist or to a gastroenterologist with an interest in hepatology. Symptoms of decompensated liver disease include, but are not limited to, ascites, encephalopathy, and gastrointestinal hemorrhage. For people who misuse alcohol, consider referral to specialist alcohol services. For people with end-stage liver disease requiring symptom control or palliative care, refer to the local palliative care team, especially if the likely prognosis is less than 12 months. Cirrhosis management in primary care. Offer the person advice on healthy eating and diet. Individualized dietary advice should ideally be provided by a dietitian, particularly for people with decompensated cirrhosis. Alcohol consumption and smoking. Driving. Give advice on driving relevant to the underlying cause of cirrhosis and the level and nature of complications. Using medications safely. Seek medical advice before taking any over-the-counter drugs or herbal remedies. When reviewing a person with cirrhosis in primary care, review medications and note whether any changes to drugs or dosage are required in relation to liver function. Seek specialist advice if in doubt. Ensure the underlying liver disease is being treated if possible, and they are receiving appropriate specialists follow-up and screening for complications of cirrhosis. This will usually be overseen by secondary care, but may be arranged by primary care as part of a shared care model in some cases. Be alert to features of potential complications of cirrhosis to enable timely detection and referral. Ascites management. Dietary sodium restriction, diuretics, and therapeutic abdominal paracentesis are treatment options. Peritoneal venous, portosystemic, and transjugular intrahepatic portoistemic shunts are also helpful. Spironolactone 50 to 300 milligrams once daily is the diuretic of choice in the management of ascites. Spironolactone is used either alone or in combination with furosemide in severe ascites. Intravenous albumin and vasopressin, V2 receptor antagonists, are used in the management of ascites. Spontaneous bacterial peritonitis (SBP) management. Patients with a history of spontaneous bacterial peritonitis are given antibiotic prophylaxis with norfloxacin, 400 milligrams daily, and trimethoprim sulfamethoxazole, 5 days a week, to prevent recurring of SBP. Patients with gastrointestinal bleeding are prescribed norfloxacin, 500 milligrams, orally twice per day, for 7 days to minimize the risk of spontaneous bacterial management of variceal bleeding. Non-selective beta blockers, propranolol, nadolol, are indicated to reduce portal hypertension. Endoscopic treatment options like banding, injection of sclerosants are indicated in treatment of esophageal varices. Management of hepatorenal syndrome. Intravenous fluids, albumin or fresh frozen plasma administration are helpful measures. Hemodialysis may be needed in refractory renal failure. Liver transplantation is carried out as the final option of treatment. Management of hepatic encephalopathy. Lactulose, 30 milliliters once or twice a day. Administration and treatment of any infection or precipitating factor, hypovolemia, metabolic disturbances, gastrointestinal bleeding. Infection, constipation should be done. Lactulose can reduce the intestinal absorption of ammonia and also facilitate the quick passage of intestinal contents, reducing the duration of absorption. L-ornithine, L-aspartate, sodium benzoate are other available treatment options. Nutritional needs should be supplied via a nasogastric tube to prevent the risk of aspiration. Other supportive care include urinary catheterization, maintaining skin and oral hygiene. Treatment of causative factors. Autoimmune hepatitis is treated with immunosuppression, prednisone, and azathioprine. Interferon and other antiviral agents are used to treat chronic viral hepatitis. Phlebotomy is indicated in hemochromatosis. Primary biliary cirrhosis is treated with ursodeoxycholic acid. Trientine, penicillamine, and zinc is used in the treatment of Wilson's disease. Anticoagulation with intravenous heparin followed by oral warfarin or subcutaneous low molecular weight heparin is indicated in BUD. Chiari syndrome. Angioplasty and stent placement will re-establish the vessel patency. Management of abdominal hernia. Massive ascites can cause umbilical and inguinal hernias. Umbilical hernia should not be repaired unless it is irreducible or strangulated. Treatment of anemia. These include hematinic, erythropoietin, or blood transfusion. Treatment of osteoporosis. Vitamin D and oral calcium supplements are indicated for patients with increased risk. Zinc deficiency is seen in many patients with cirrhosis. Zinc sulfate, 220 milligrams orally twice daily, is the recommended treatment. It is also effective in preventing muscle cramps. Zinc is indicated in patients with Wilson's disease as well. Vaccination. Patients with cirrhosis should be vaccinated for hepatitis A, influenza, and pneumococcus. These infections increase the morbidity and mortality in patients with cirrhosis.